It's another Thursday, another opportunity for me to answer your questions, and thank you so much for sending them all in. I'm Dr. Amy, and I'm so excited to be here today. This is a place where science meets heart and maybe a little humor. And sometimes I'm the only one laughing at my jokes, but that is okay. On this show, I start with your pre-submitted questions and then switch gears to take live ones straight from Instagram. You can always join in real time. You can always submit your questions. Tune in back later. If you submit a question, we always message you and let you know that I'm going to answer your question live and on what day. And we'll always send you a copy of my answer. Not that anyone's going to go back and listen to it, but if you wanted to, you could if you wanted to. So let's talk about today's topics and what we're going to cover today. Okay, so we're going to talk about sperm health, embryo testing, fibroids, ovaries, always ovaries, and more. So thank you for sending in your questions. I know it takes so much courage to be a fertility patient now more than ever. And I'm going to start with our first question. So let's get started. So the first question comes from Brienne. She's 35 from Canada, and here's her question. Hi, Dr. Amy. I'm just going to bend my little question card here. My husband's on Dutasteride for hair loss. Still uses hot tubs because his sperm tests were normal. I think I need to send him a shot glass that says, don't cook your balls. Send me your address, Brienne. I got to send one to him. We've been trying for a year with unexplained infertility, done medicated cycles, and we're moving to IVF. Should he stop these things? And the next question is, how do we get genetic profiles checked in Canada? Let me just start with the easy question. Carrier screening. So carrier screening, basically you want to make sure that you and your partner don't share common genes for diseases that could be lethal. There is a very easy way to get it done in Canada through your fertility clinic. iGenomics has carrier screening. So iGenomics is a PGTA company, but they also offer carrier screening in Canada. That's the easiest way to do it. I believe their panel has over 500 genes. So that's one place to start. Your doctor should have information about how to get that done. So that's what I would do if it were me. To answer your questions about how to prepare for IVF, given your husband's lifestyle, I would say hot tub can definitely affect sperm. Encourage him to stay out of the hot tub, and then he can jump right back into the hot tub after egg retrieval day. Think of sperm like delicate snowflakes. You don't want to put them in the sauna or hot tub or expose them to extreme heat. Snowflakes will not survive, so don't freeze your balls, don't do cold plunging, don't cook your balls. I think I said balls enough. But if you want to learn more about balls, this is true, you can go to a website. I kind of have a GoDaddy problem, not a daddy problem, but a GoDaddy problem. I buy websites. So you can go to ballsmethod.com and you can learn all about the things that I tell my patients about when it comes to sperm. To get to your question about Dutasteride, this can affect sperm quality. It blocks DHT, which is part of the testosterone pathway. So while his sperm numbers might look normal, and I bet and some guys say this, they say things like, my sperm count's normal, and I've been doing this on in the hot tub. Why can't I keep going in there? And I totally get it. But there are subtle things that heat and testosterone blockers can do to sperm. So my recommendation is to stop it at least 2.5 months before your egg retrieval. If you're planning an egg retrieval, really soon, try and plan at least 5 weeks of being off that medication. So I think it's worth stopping. Sperm life cycle is around 72 days, so that's how long it takes them to regenerate. I wish eggs were like that. Wouldn't that be amazing? Like, we're not born with all the eggs we ever have, and age doesn't damage eggs the way. So I wish that eggs had that we were lucky with eggs the way that men are lucky with sperm, but that's the good thing. So any exposure to his sperm right now, basically in 2.5 months, his sperm will be like, what? I'm not Olaf anymore. I don't know if that joke made sense, but it kind of made sense to me when I said it. So this next question comes from Mariah. She is 41 from Washington, White Salmon, Washington. And she shared something really endearing. She said, your show helped me through 3 cycles of IVF. And now I have my 11-month-old daughter plus 3 PGT tested embryos. One was originally labeled chaotic, then re-biopsied and found to be euploid. My old clinic said it's fine if it survived thawing, but the new clinic doesn't want to accept it. What do you think? So Mariah, first of all, congratulations on your daughter. And I love that you called in from, or sent in this question from White Salmon. I mean, that's a pretty cool town to be from. So let's talk about your comeback kid, so to speak, embryo. So you guys have heard me say this all the time. One of the most important things before you do PGT and IVF is your consent forms. And when you sign your consent forms, make sure you sign, I do not want to discard abnormal embryos. This way you can actually review the report and then make decisions about what you want to do with these abnormal embryos. Chaotics are considered abnormal, and if you had not advocated for yourself, you might have discarded that embryo. And now we know, after years of research, that the chaotic embryos are kind of like, you know, in the old days, when you used to turn on the TV and it wasn't working, you saw all that white noise. But your TV, you know it still works. You know it's still a good TV, but you just have to wait. So chaotic embryos are kind of like that. It's kind of like white noise. And it's not that they like self-correct. It's that the data is just all, you know, blurry and you can't really tell if the embryo is normal or not. So statistically speaking, chaotics have an approximately 40% chance. I did just say that. 40% chance of actually being euploid, which means chromosomally normal embryos. So if you didn't know that, you might have missed an opportunity to potentially have a healthy baby from that embryo. So I've done things a number of different ways with patients. One of the things that I've done is say, let's just transfer the chaotic and see what happens. But if the embryo is really strong, meaning the quality of the cells are good, and there are enough cells in the placenta or the trophectoderm to justify doing a double biopsy, then I'll go ahead and re-biopsy the embryo, because re-biopsying the embryo can actually decrease the implantation rate of a blastocyst. So it's important for you to know that before you make the decision to retest it. So I'm really glad that you know that this embryo is chaotic, but I would actually choose to transfer the embryos that only had one biopsy first ahead of the chaotic. And it is not unusual for IVF centers not to accept embryos from other labs. That's kind of what is the culture right now amongst IVF clinics, except here. So I accept embryos from all over, including overseas, so clinics that are in other countries. I also accept international embryos, but we are very careful about what we do first. We look at the thaw protocol, we look at the straws, how they're labeled, and we make sure that we know the thaw protocol and we can actually bring those embryos here before we do that. What that means is you want the embryologist to have an experience with that kit so that you can have your embryos thawed safely. And I've done that, I don't know how many embryos I've moved, like over 1,000 over the years, and the survival rate is 99.5%. In fact, true story, I don't think I've had a single embryo not survive in probably over a year. So that just shows you how good the embryologists are in the Bay Area. So the next question comes from Maria, 44 in New York. My embryos keep arresting at day 6 or day 7. Should I consider a day 3 transfer instead of pushing for blasts and PGTA? So Maria, you're asking the classic question. I get this all the time. Day 3 versus day 5. Let's break it down. So this is the conversation I have with my patients. I say, look, if we grow your embryos to day 6 or 7 and we don't have a blastocyst, will you feel emotionally like you missed out on an opportunity to do an embryo transfer? So basically what I'm saying, what's more important to you? Making sure an embryo has passed genetic screening, or having an embryo transfer and giving every single embryo a chance? So you have to answer that question for yourself. And anytime you get pregnant, even with a screened embryo, you're also subconsciously saying, I accept the risk that is, I accept all the scenarios that can happen in pregnancy, including miscarriage, including an abnormal pregnancy. I don't think it's dangerous to transfer an untested embryo at 44 at all. Most abnormal embryos actually won't even implant. And if they do, they usually end in a very early miscarriage. But for some patients, experiencing a miscarriage can actually cause them deep emotional pain. Most women experience deep emotional pain, don't get me wrong, when you go through a miscarriage. But for some people, they would actually rather not have the experience of a miscarriage, and they would choose genetic screening of their embryos and only transferring if their embryo has passed screening. So I know that's a lot, but that's the conversation that I have with my patients when I make these decisions with them. And you also have to ask your clinic, because some clinics actually will not. I mean, it's interesting that there are clinics that don't give patients permission to do the things that they want to do, but some clinics will not let patients transfer day 3. They're a blast culture freeze-all only clinic. So talk to your clinic about what their protocols or policies are around transferring day 3 or even freezing day 3. So that's another thing that I do. I'll bank day 3 embryos for patients who are over 40, especially if they have a history of not making blastocysts, because most of those blastocysts will come back abnormal. And this allows us to bank embryos, and then once we're done with that journey, then we can go ahead and transfer. Because if you were to transfer before you're done banking and end up with a miscarriage, that can basically rob you of a fertile window that you wish you had. So I hope that all made sense. I hope that answer was helpful, and I hope that whatever you do next is going to be successful, obviously. This next question comes from Miko, 37, from Fremont. I've done 2 IVF cycles. One was canceled due to premature ovulation. My right ovary is a superstar. My left ovary is lazy. Well, let's not call your embryos names, or your ovaries names, I should say. And the question is there anything I can do to wake up my left ovary? Okay, Miko, I love how you described your ovaries. They sound really fun. This is what I'll say. I get this question all the time, and patients often ask me, like, does it help if I inject on one side versus the other side? And typically, it's not unusual to have asymmetry. Like, one ovary will have more follicles than the other ovary. That's quite common. And I wish there was a thing that I can do to get them both to have even more follicles and both respond. But that's just part of having ovaries. We can't predict which ovary will have more and which ovary will respond. So there's really nothing that we can do to get the one side to be more active and to be less lazy, as you put it in a really cute way. I wish, like, if you kissed your ovaries, which I tell my patients to do, that would help, or if you hugged your ovaries. But there are things that are a little bit outside the box that I offer patients that might help increase the egg count overall. So if you guys have been listening to Ask the Egg Whisperer, you know that I've been talking about these things for a while now. One of them is a repurposed drug called rapamycin that might increase your egg count. I can't promise that it's going to work for everybody, but so far it looks really promising. I just submitted a case series to a major medical journal, kind of sharing the experience that I have with this medication so that hopefully more doctors feel comfortable using it. The other thing that you can consider, and I've been doing this for a while now, is ovarian PRP. That might help increase the number of follicles in both ovaries, especially your left ovary. And then I also think the use of supplements like Ova NAD+, CoQ10, resveratrol, a good prenatal, and then all the lifestyle things that you guys all know about, like eating healthy, sleeping well, hydrating, listening to Diplo. Yes, Diplo is my boyfriend. He just doesn't know that yet. And in fact, segue here, I am going to the Diplo run. This is coming up soon, so I hope that you will all join me. The team is registered as Egg Whisperer, so if you guys are in the San Francisco area, and even if you're not and you want to join us for a fun run and then an EDM concert afterwards, please join. It is a blast. So thank you for sending in that question. So let's go to our next question. Our next question comes from Juliana. Juliana is 39. And she's from Maryland, and this is her question. I did IVF and I had 17 eggs that resulted in 4 blastocysts. All were normal and passed screening after PGTA. Now I've learned I have fibroids, 1 inside the uterus and 2 outside. Could these be my major issue? So that's a great question. First, amazing work getting 4 normal embryos. Congratulations on that big win. That's literally IVF gold. So now let's talk about the fibroids. And the way I think about fibroids are like party crashers, right? Like some sit outside quietly and they don't bother anybody, but others are like blocking the dance floor. They're like your drunk uncle at the wedding. Everyone has that drunk uncle or the drunk uncle that kind of blocks the dance floor and kind of ruins it for everybody. So the one inside the uterus, if that's what you have, is also referred to as a submucosal fibroid. This is the one that's most likely to interfere with implantation you want to have addressed. And you want to be really careful about who does this kind of procedure. While OBGYNs can do these kinds of procedures, I highly recommend you see a MIGS surgeon, a minimally invasive gynecologic surgeon. So these are OBGYNs who did extra training in removing fibroids in a way that will restore your fertility and make your uterus amazing again. They'll clear up that dance floor and make sure that there is plenty of space for your embryo to stick and grow. The fibroids that are in the walls of the uterus or outside the cavity, I recommend removing them if you're symptomatic from them. And what I mean by that is if you have severe back pain, you're peeing all the time, you're severely constipated, maybe they're causing other problems, like they're blocking your ureter and they're causing something called hydroureter. Well, those things can actually get worse in pregnancy. I tell patients there's a rule of thirds when it comes to fibroids in pregnancy. 1/3 shrink, 1/3 stay the same, and 1/3 get bigger. So 2/3 of the time, they actually don't cause any problems. But 1/3 of the time, they can really cause problems, and they can even degenerate in pregnancy, cause lots of pain. So talk to your doctor about what they think about your fibroids. Get an expert opinion from a minimally invasive gynecologic surgeon. And, you know, I don't like to think in worst case scenarios, but I think it's really important. Patients really like to be informed about everything pre-pregnancy. So I think it's important to talk to your doctor about, like, what are all the things that I should be considering given my fibroids about my pregnancy? What are some of the complications that could happen? I just want to hear about everything up front and everything right now so I can make the most informed decisions for myself before I start my transfer journey. So thank you for sending in that question. Fibroids are really, really common. We see them a lot. They're fairly straightforward to remove. Most patients can go on to have a very healthy pregnancy and delivery after removal. So this next question comes from Veronica in Texas. So here is her question. I had a tubal reversal. I'm 42. My AMH is 0.05. My ovaries looked small. My doctor only saw 2 antral follicles. My Anita shows that I am ovulating and my lining is 12 millimeters. I'm on vitamins. What do you recommend? So, Veronica, I love your determination. It is very obvious you have hope in your heart. I'm sure you know what an AMH of 0.05 means. It means that the chances are not 0 yet. So it's wonderful that you're still ovulating. You're not a number to me. So I don't define patients by their AMH levels. I give everyone a chance. So let's talk about where to go from here. So the first thing that I would do is when you've had a tubal reversal, what that means is you had your tubes blocked and then you had that reverse, so hopefully they're open again. So the first thing I would do if you have not done it is repeat or do an HSG. So that's a hysterosalpingogram. So that's a test of your fallopian tubes. We want to see if the tubal reversal worked or not. We want to see if IVF is actually the only way that you can get pregnant, even though you had that tubal reversal. Check the sperm out also. Make sure the sperm is good so that you're not wasting your time with all these efforts, potentially trying naturally when potentially the sperm needs a little bit of a boost. So you want to get that sperm boosted as soon as possible. So I talked earlier after I answered a previous question about some of the things that I do in cases, and in that particular question, someone was asking about a lazy ovary and what she can do to potentially get more eggs on that ovary. And the same applies to you. So the same things, supplements like Ova NAD+, CoQ10, resveratrol, a really good prenatal, all the lifestyle things like basically getting in the best shape of your life. And I talk to my patients about the 10-minute mile rule. So what that means is I wanted you to be in such good shape that I can say, hey, I'll meet you outside, join me in 5 minutes and we're just going to go jog a 10-minute mile. And what you have to say is like, Amy, totally, let's go do it. I can totally do that. I'll meet you right now. What you can't say is, I can't imagine being able to do that. So I want you to be fit enough to be able to do that. I think being fit and healthy also helps with your fertility, although obviously it's not everything, but it also helps you with having a healthy pregnancy. And then you can consider some of the outside of the box things if you're open to it. So what I mean by that is rapamycin, ovarian PRP, in addition to the supplements. And my approach to care in a case like yours is just keep showing up. Be as thoughtful and creative. And I don't like the word aggressive because I like words that are gentler when I communicate with patients. But I want you to just show up every time you have a period. Have your doctor take a look at your follicles and then put you on medications to help you grow that cohort. So what that means is ovulation augmenting medications like letrozole, what I jokingly call letrozole, right? It sounds like a very Italian word. It's way more fun if you say these things with an Italian accent. And then your doctor can monitor your response. And if it's an amazing cycle, let's say out of the blue, you're ovulating, let's say 3 or 4 eggs, then you can consider converting the cycle to an IVF cycle and, take advantage of your great response and then try IVF if your doctor thinks that that's a good option for you. Or you can try naturally, or obviously with IUI, which is basically a medical turkey baster where you take the sperm and you insert it gently at the top of the uterus with a tiny thin catheter, injecting the sperm as close to the eggs as you possibly can. So that's what I would do in a case like yours. I would tell you your chances are not zero. They become zero for all of us at some point in our lives. Menopause is coming for all of us. And as long as you're still ovulating, even though your AMH is 0.05, there is still a chance. It's low, but it's not no. So I would go ahead and, as long as you have hope in your heart and going through treatments isn't going to be too emotionally, physically, financially taxing on you, I would keep showing up. And then I would tell you, if you were my patient, let's give this 6 months and see what we've learned, and then see if it makes sense to keep going, or if we should start talking about other options. This is a good time for us to do it. So thank you for asking all those great questions, you guys. Fertility can feel like you're climbing a mountain in flip-flops at times, or even barefoot, but you're not climbing it alone. You have people like me. You have fertility doctors that are really caring, and they really, really want to help patients. One of the nicest things a patient ever said to me, I'm not sure if it was nice, but she said, Dr. Amy, I think you want me to have a baby more than I do. That was a little bit different. I wasn't expecting her to say that, but it's true. And you want to find someone that's as invested in your journey, who makes your priorities theirs from the very beginning. And I know that's hard these days, but there are doctors like me out there. So I want each and every one of you to find that person who believes in you, who's going to cheer you on and give you the best chance no matter what your situation is. So if you want to ask a question for a future show, head to asktheeggwhisperer.com. If you want to dive deeper, join me in one of my IVF classes. You can go to eggwhisperschool.com, and you can also sign up for a consult through my website. On YouTube, all my shows are there, and that's where I love answering questions. So if you want to, jump on YouTube, and if there's a show that, resonates with you, our last show was on adenomyosis and endometriosis. The comments are always open, and I can answer your questions there. So before we end today's live Q&A, or Ask the Egg Whisperer, we're going to start our live Q&A now, and I'm just going to scroll through and go through your questions as they were being answered from the beginning. So I saw a few coming in. And the next question is, I have a history of fibroids, a clear cervical canal, but fibroids in the wall, 5 transfers, and they've all failed. All embryos are tested. What testing can be done before another transfer? So what I would say in a case like this, just briefly, I can talk for hours about a case like this, but if you have not had a pelvic MRI, I highly recommend one. And make sure they're looking for adenomyosis. So sometimes fibroids can look like fibroids on ultrasound, but they actually might be adenomyomas. And these are areas of inflammation in the walls of the uterus, and they create inflammation basically around the cavity and make it very hard for an embryo to implant. Surgically removing them really doesn't work that well. However, there are medications that you can take that can help shrink them. So typically in a case like this, I'll look at your uterine volume. I'll put you on one of these medications. The names of these drugs are Orlissa and Debolupron. And I'll put you on this drug for a certain period of time. Then I'll monitor the size of your uterus, and then we'll decide how long it makes sense for us to be on them. Basically, I just get this overwhelming feeling that we're ready. And you'll get that feeling with me because you'll see my face, you'll see the screen, you'll know the volume, and then it's go time with your transfer medications. And there are a whole bunch of other things that I also do in cases like that. Make sure your tubes are open. I talk about uterine PRP. It's just me, myself, and I. All 3 of us, we do implantation testing, meaning I also like to rule out silent endometriosis. endometritis and do an ERA test if it's something that I think that would be helpful for you to do. So this next question, I have a failed FET transfer. I wanted to do an ERA test, and now I need to do it. We're pausing and doing testing, going on a GLP-1 and eating healthy. Anything else I can do? Well, I'm totally all for a GLP-1, eating healthy. 2 thumbs up from me. In addition to what you already mentioned, you mentioned the ERA test. Since you're already going to do an endometrial biopsy, and I'm doing this because basically we take a tiny little catheter, put in the uterus, we withdraw on the back, and in come cells. Okay, so you have all these cells. It's basically tissue from the lining. I highly recommend that you do as many tests as you can to learn as much as possible because you're going through that experience already. Why not be super efficient and learn as much as you can? So in addition to the ERA test, I would recommend that you also do the EMA and ALICE test, looking at the microbiome and uterine pathogens, and then also do the Receptiva DX test. I just rattled off 4 different tests, but it's not necessary to do 4 biopsies. You still do 1 biopsy. 1 tube goes off to the company that runs the ERA, EMA, and ALICE, and the other tube goes off to the company that runs the Receptiva DX test. You get results within about 2 to 2.5 weeks, and then you really have a really good idea as to basically what you're missing. So those are some of the things that I think about and do, in addition to uterine PRP 3 days before transfer, taking L-arginine and vitamin E with your transfer medications. If you haven't done a modified natural protocol, that's what I would recommend for transfer because I think the pregnancy rates are higher than controlled. There's another medication that I also use called Neupogen for patients who don't have a first successful transfer, and they start that on transfer day and then continue until they have a heartbeat or 10 weeks of pregnancy. And also the antihistamine protocol, which is Claritin 10 milligrams and Pepsid 20 milligrams twice a day, starting 2 days before transfer until 10 weeks of pregnancy. So I know that's a lot, but those are some of the things that I think about in a case like yours. So I think there's one more question. I did IVF and I got 15 mature eggs and 15 fertilized, but 5 made it to blast, and I sent them to PGT. What are the chances of euploids with such low numbers for blastocysts? So what I would say at 36, that number is actually fantastic. I know it feels like you lost a lot because you went from 15 to 5, but the way I emotionally prepare, or how I help my patients emotionally deal with results that feel negative, is I say, look, you went from 0 to 5. You had 0 blasts yesterday, and now you have 5. That's huge. So the whole 15 to 5, that's not a thing. It took 15 eggs for you to get 5 blasts, and you had 0 blasts at the beginning. So 5 is actually quite fabulous. I would consider that a fantastic cycle. I predict that you'll get at least 2 or 3 that pass genetic screening out of 5. At 36, each one has approximately a 50-50 chance of passing genetic screening. So you might even find more than 5, not 5 because it's 5. You might learn that all 5 pass genetic screening. So let's see what other questions we have today. I think that might be the last one that I saw. Oh, no, there's one more. What type of trigger, let's see if I can do that again. What type of trigger protocol do you use for patients who are 40 with DOR? Pregnal only, pregnal and Lupron? Please discuss why. I have 7 follicles responding. Doctor hopes to retrieve 4 to 5. I'll typically do a 10,000 HCG trigger. I'll do a dual trigger. Let's say if a patient has a history of low maturity, or opposite of DOR, if someone is a over-responder and I want to prevent OHSS. So I don't have a one-size-fits-all trigger protocol. I typically will do HCG only or a combination for those reasons that I just shared with you. That's a great question. Next question is, after 1 miscarriage, when can you try again? So from a medical standpoint, there's no reason to wait. I've heard doctors tell patients, not fertility doctors, but OBGYNs tell their patients you need to have a few normal cycles first before you can try again. Or I've even seen doctors put patients on, let's say, birth control pills for 6 months or a year to recover. The reality is, once you ovulate again, you can try and get pregnant again as long as you feel ready to do that. If you've had 3 miscarriages, which is what this person just added, and I'm sorry that you've had that experience, there's a whole workup. So angelmethod.com is like is one of the websites that I have that kind of explains what you do if you've had miscarriages. So we look at your AMH to see if it's related to ovarian reserve. I do autoimmune tests. I look for conditions like adenomyosis, uterine anomalies. We talk about nutrition. We do genetic tests like chromosome testing, carrier screening. We look for endocrine issues, look at your BMI and your lifestyle. So those are some of the things that we do if someone has had 3 miscarriages. So I'm sorry that you've lived through that. And hopefully with a workup, you can figure out what the best next step would be for you so your next pregnancy does not result in a miscarriage. Okay, you guys, I didn't realize that there were so many questions. So I appreciate you guys all sending them in live right now, but I'm going to hop off, and I hope you guys will join me for the next Ask the Egg Whisperer live next Thursday. And if you have lots of questions and you want to have more time listening to me answer them, a great place for that is my IVF class. So that's eggwhispererschool.com. I have a class at least once a month. So I just kind of talk about fertility for not that long and then open it up for a Q&A, and I just basically stay until all the questions are answered. So thank you guys for joining me today.